We've got two new panelists joining us. Dr. Willie Wint will be chairing this discussion from the University of Oxford, and Eden Next, and plenty more affiliations. And Dr. Julian Medlock, I'm sure you're all familiar with him. He's from Public Health England, formerly HPA. So please join me in giving them both a very warm welcome. They've just joined us now.
Good morning all, my name is William Wint. The last time I did this I was challenged to justify my existence since I wasn't actually speaking. So for the two new panel members, just a minute or two to explain who we are. I'm basically an entomologist who's graduated into spatial analysis and modelling, involved in a fair number of the ECDC initiatives that we heard about from Josep this morning. And also actually developing with the European Space Agency, together with Julian, a suite of tools for vector surveillance and spatial modelling. That's me.
Hi, I'm Julian Medlock. I'm a medical entomologist and disease ecologist at Public Health England, which was the Health Protection Agency, which is part of the UK Department of Health. I started my career, I trained at Liverpool School of Tropical Medicine, started my career in malaria diagnosis and malaria control in Africa, and then came back to Britain, spent the last 10, 11 years advising the UK government on the risks of vector-borne disease, and you saw from the presentation earlier that the number of risks posed by vector-borne diseases in Europe have increased enormously. We conduct tick and mosquito surveillance for the UK, that's for endemic species and also for invasive species, and conduct risk assessment field-based research on those risks as well.
Thank you, Ryan. You've not had any opportunity to ask questions of any of the speakers, and I'm sure that now you've had a little bit of time since they've spoken, I'm sure some of you have some questions, so I'd like to provide an opportunity for you to do that. I will endeavour to write them down if you have any, and then we can pass them on. Does anybody have any questions for the speakers that they would like to ask?
I'm Dr. Daniel Arkwell from Sentinel Diagnostics. A question for Dr. Perkins, if possible. Looking at your presentation, it seems that you've tested an awful lot of malaria detection assays, over 200. Some of them are doing very, very well. And you've also done quite a lot of work with the Cepheid system. My question is simple, really. Do you think we've nailed it in terms of detection of malaria? And if not, what are the next big challenges out there?
I think for the case of detecting clinically relevant parasitemia in moderate to high transmission areas, we've nailed it. As long as you're using assays that work relatively well, it's simply a question of getting the assays, the correct assays, distributed, lot tested, and used with trained people who are going to respond to the results. So I think in terms of the diagnostic work, that's quite well done. What isn't done is two major issues. Is that one is the more we do a good job controlling malaria, and the less prevalent malaria is, the more negative tests there will be per positive test. So currently in Zanzibar, they're testing 150 rapid tests to find one positive, and it gets pretty boring after a while to be a health worker and do that, and it also becomes costly. So I think if we're going to have people continue to test for malaria, we need to add value to that testing. Surely we can find ways to give additional value to the test itself that tells people whether there are other health indicators that are useful to track, whether they have dengue instead of malaria. Multiplexing is complicated, not so much technically, but from a business model point of view. No one wants to pay the extra 10 cents for the disease that they don't think they're coming in for. So and the more you add those up, the more it becomes an issue. But I think the future is likely to be toward multiplex testing if we can crack that issue. The second area that's not done is, of course, strategies for diagnostic testing, for strategies for elimination. What do we do when we get down to the odd outbreak in a small village in areas that are otherwise malaria-free? What kind of surveillance do we have? How do we track the appropriate use of distribution of bed nets and residual spraying or other interventions? Are there serologic rapid decay antibody responses that we could use to indicate where levels of transmission are occurring and do that in an annual way and help the government use their resources more wisely. I think we're a long way from having the diagnostic tools to really drive elimination to success.
Are there any other questions that people have for the speakers?
Hi, it's Matt Forrest from Twist Diagnostics. I was just wondering if you could tell us, Mark, for the LAMP TB test, there's no internal control, right? So do you have any idea what kind of false negative rate there is for that?
Yeah, there is no internal control. There's an external control, but it just runs per run, and there's no internal control. And unless we completely rebuild the assay, it won't be possible to do so. The false negative rates are hard to estimate. If we run them with, if we put a known number of genomes that it can detect in, and we test hundreds of tests per lot, we don't get any false negatives. The false negatives don't seem to be much affected by undue exposure of the reagents or other adverse conditions. False positives do. That's another separate issue. But there are three issues with LAMP that make it imperfect, at least. One is that it's not very quantitative, and the second is it's impossible to multiplex in this platform. And the third is you can't put an internal control, which is sort of the same issue. It does have those attractive features otherwise, and so it's always a question of how much we can give away.
Thanks.
Any more? Okay, well, before this meeting, the organization sent round an email to those of us who were participating saying, what questions do you think are important in this field for surveillance? And the list is really quite long. So I've been sitting trying to reduce it down to a number of things, and I'd like to give an opportunity to some of the speakers to respond to this, and also any comments from the floor. We would like to make it as inclusive as possible. We've heard this morning a lot about surveillance of diseases. We haven't heard a great deal about surveillance of vectors. It's been mentioned, but it's not very high up the list, it seems. And one does wonder whether the surveillance of vectors is seen by you and by some of the speakers as a priority that should be raised in profile, particularly in the developing world and I suppose in Europe. The other thing is whether, we've heard a lot about data being gathered, but we haven't heard a great deal about it being shared and given out to people so that researchers can actually use it and take advantage of those things, because it's a very rich data source. The crowdsourcing, yes, and that. And the other question that seems to have come up quite a lot here is, how do we get the results of surveillance into public health policy? Because again, there seems to be quite often a disconnect between lots of people busying about getting lots of information about specific diseases or specific vectors, and very often they're not the questions that the public health people actually want answered. So do we need to establish those connections? So having talked a little bit and given hopefully you time to absorb some of those questions, and I'd like some sort of response from some of the speakers. Do any of you have any response to the data sharing or the priorities between vectors and diseases, and some way of how we can actually translate some of this information and how the public health people can have an informed input into this?
I'll take a shot at it.
Please, yeah.
I mean, there's a clear correlation between the prevalence of infected malaria in a community and the abundance of gametocytes circulating in the population on which they feed. Mm-hmm. And one can, and there are similar correlates for many of the vector-borne diseases. One of the issues that makes it difficult, for example, in human African trypanosomiasis, is that you have to capture about 10,000 tsetse flies to get a very good yield and it gets to be quite laborious. And to do surveillance where you'd have actually a usable population number of positives, say 100 positives, you're talking about 1 million tsetse flies captures, and this tends to be hugely burdensome. So I think there are specific issues where, especially if you're looking at strains as they circulate in the community, or if you're looking at vector habits, that you might want to test the vectors themselves. But sometimes it's a shortcut, especially in low prevalence diseases, to look at the patients themselves. A quick note on information and sharing of data. It's a complex area. We have a project with our partner Cepheid where we are connecting all of the instruments that are in settings where there's internet connection, which is a couple of thousand. And all of these now are linked via a cloud server, if you will, that is able to download all of the data on not individual patients, but on the performance of the instruments. So you can say, show me anywhere in the world where there's rifampin prevalence above 10%, and it will highlight every instrument. Show me any instrument that's not been used for a week, and it will highlight every instrument, etc. The same system also, under password, downloads the numbers of positives and negatives to the public health community in country. Those are nationally owned data, and those countries then can decide whether they want to upload them to more broadly. Most decide not to. And it gets to be, there are under HIPAA in the United States and other laws in the UK, very tight rules about the sharing of confidential information from patients. De-identification is a legally variable term, so we just have to be very careful about how we do that. I think one of the projects we have with WARM is looking at the prevalence of an incidence of different causes of fever that are non-malarial and trying to map those out through the literature. And it's true that it is a vast desert of wish you had the data field.
Please.
I can speak to two of those topics as far as the Global Trachoma Mapping Project is concerned. So as far as data sharing goes, we're in a very similar position to the position that Mark describes, in that data are owned by national governments, but it is a requirement from the funder in DFID that the data are available for public health use. And that means that the prevalence categories, rather than saying that in a particular district the prevalence of TF is 15%, we are required to demonstrate on a publicly accessible platform that the prevalence is at a level that requires intervention. So that for that reason, the prevalence categories are displayed on the publicly accessible Global Atlas of Trachoma and are almost immediately available for public health planning as soon as they're captured. So we can finish collecting data on a 26 cluster population-based prevalence survey today, and assuming the Ministry of Health people are available to clean the data, to approve the data, and there aren't many problems with it, tomorrow the data can be available at ITI and ready for approval of a drug donation for that district. I think that's quite key. Having data available for researchers to use is a different question because they're owned by national governments, but it's something that can be addressed.
I think it's worth pointing out also that the reverse is the case. Very often researchers produce information and hang on to it for as long as possible. I mean, I run a data archive for an FP7 project, and it's hell's own job to get the data out of it.
That's certainly one thing that we really wanted to avoid, and that has been a drawback of most trachoma surveys in the past, that they've been planned and executed by an academic group by and large. The data are collected and they're usually, or hopefully usually, used in the right way for public health planning purposes. But the broader data themselves stay on that person's PC or laptop, and when they change jobs or get hit by a bus, they just aren't available.
Any other comments from Simon?
We run, I think, the Malaria Atlas project, and that has collected now something in the order of 30,000 malaria prevalence surveys. And I'm a little bit more optimistic than both of those. We got permissions from about 2/3 of the people that have provided data to distribute those in a fully open access and free way. So if you keep hitting the relevant people in the governments and the relevant academic researchers, I think you can change the culture a little bit. I think it's beholden on us all to keep trying to push that particular agenda.
Yeah, I agree. Please.
Yeah, also to add something to what has already been said, one of the aims of these networks that we are dealing with in ECDC is also to try to gather and to share as much information as possible and to have that link between human health and vectors health and vector surveillance, sorry. So, but as has been previously said, there are many different challenges, and it's the heterogeneity of data that are coming from different countries, the different strategies that are confronted, and then what is the real framework or the representativity of the data that you have. No matter of that, I think that, as said before, one of the aims of the EVD group in ECDC is just to try to share and to put together the different strategies for human health, vector control, and vector surveillance, and try to gather as much evidence as possible to figure out what can happen in the near future when the coming outbreaks are going on and things like that. But of course, there are a lot of different challenges, as said, as the representativity and how the efforts that you have to do, the different constraints that member states are facing in terms of human surveillance and also with vector surveillance, and those kind of issues are those that we have to take into account in order to figure out which is the better strategies to deal with those new challenges.
If I may say, in your talk there were also hints that you were moving towards a One Health approach. I mean, you mentioned a couple of livestock diseases, for example.
Yeah, that's, to some extent that's the issue. So that's why we are working closer with other UA agencies such EFSA and developing common projects that are putting together the information that we gather in different agencies and the UA.
Jolene, I can see you jumping up and down.
Yeah, I guess someone who has to justify vector surveillance to a European government, I guess perspective I have on this is that if we're looking at vector-borne diseases in the tropics, we know we have the disease, we know that it has a large health burden, the focus is on controlling the vectors and dealing with the human cases. In Europe, we're at a slightly different stage, is the fact that we don't necessarily have that many large-scale, heavily burdened diseases, except probably Lyme disease, and we're preparing for what might happen. And as part of that preparation, I'm sure that goes on in ECDC, I know it does, is that risk assessment. What is the risk of these potential these tropical diseases becoming a European issue, or European vector-borne diseases becoming more prevalent? And part of that requires some understanding of whether we've actually got the vectors. Now, I think we've probably, previous generations probably presided over a period of inactivity when it comes to vector surveillance in Europe. I know even from the UK, much of the work on British mosquitoes was done in the 1960s. And since then, a lot of focus naturally has been towards tropical regions. But now we're faced with things like West Nile virus, which infect a number of different mosquito species, malaria in Greece, invasive mosquitoes. Do we actually know, and also the rise of Lyme disease, what are the reasons for that? Is that an increase in the distribution of ticks? If we don't have that baseline data, we can't then project forward and work out what the driving forces are or where these increases are. So there's a real need to establish a baseline of where mosquitoes are and where ticks are from a European context. And from that, we can make a risk assessment. I'll give you one example. In the UK, there was a risk assessment done on West Nile virus about 10 years ago, and one of the conclusions of that was that the principal vector, Culex modestus, had not been seen in Britain since the 1940s and only in one location on the south of England. However, there had been no real evidence to say that the surveillance had been done to actually look for it. In 2010, we found it in North Kent, and this year we found it actually prevalent and in high abundance across North Kent. So if we don't have this vector surveillance, we don't accept we have to update our maps. We're making pretty poor risk assessments, and therefore we get caught out when these outbreaks occur. With invasive mosquitoes, and I'm heavily involved with VBORNet, with ECDC, I think that's been a real success. I think public health bodies, governments don't always communicate with medical entomologists and make sure that data is being gathered. With invasive mosquitoes, we've been able to actually establish a program and monitor the spread of a number of different species over the last few years. And now, of course, we have dengue and we've had chikungunya virus. There are some issues with how that data is reported. I mean, we coordinate the tick database on behalf of ECDC VBORNet, and some of the data is collected in different ways. Not only a handful of countries in Europe actually conduct surveillance for their ticks. and most of the data is reliant upon research articles. So there's a real data mining, as I'm sure Simon's done a lot of this as well with the diseases. He's trying to work out how good that data is and what the spatial resolution is. And then Willie's heavily involved in trying to use that to actually create predictive maps. So from a European context, hopefully I've made the case for vector surveillance, but I can understand why that might not be a priority within tropical regions.
Thanks, Johnny. Please.
I'd like to ask the panelists and the public about what do you think which is the role of new data sources or big data, social media, crowdsourcing, information about human behavior that comes from mobile phones or transactions in surveillance? I mean, is there a new generation of surveillance methodologies, or you think it's really far away?
I think we are already seeing in surveillance is that it's different strategies that can be managed. As we have the classical surveillance, that is what you are systematically collecting by the traditional ways of collecting data. But there is much more than that, and that to some extent is what it's done, and what in this area that we call epidemic intelligence. So we try to gather as much information as we have for official and unofficial sources, and that's room for introducing many other strategies that we can have, such as what you are saying, collecting data immediately from the field, and as some examples that you have been seeing, and many other different strategies that, by one hand, those things can be done for diagnostic purposes and for those objectives, but also for surveillance, trying to making sample size and try to identify how significant is that from one specific area. So I think that it's a lot of room for improvement in many different areas, and some of the examples that you have been managing are very good for that.
I think I should point out there that there are a fair few apps and tools out there now that are beginning to be developed to address some of those problems. We heard about one this morning, and I've been involved in another one. I'm getting hassled here for time, and essentially saying, if you want coffee, now is the time to go and have it. So I would suggest that if you do have any questions, we'll be at coffee, back us into a corner, and then ask your questions there, where the answers might be a bit more personal. So I think, can you join me in thanking all the speakers this morning for some excellent and very interesting presentations from my point of view. It's been fascinating to learn about what goes on with diseases when I personally am mostly involved with vectors. So please join me in thanking the speakers.